So if you take AML in general, about half of those patients will have 40 to 50% of them will have normal karyotype AML. In these patient population, typically we use molecular data. Now, there have been several studies to look at the molecular landscape of acute myeloid leukemia and try to classify those patients, though it's still kind of not very well done in general. So there is now what we use is the European Leukemia Network classification, and these are great classification, though it's really based on experts' opinion. Not much more on data. So for example, traditionally we have choose NPM1 mutations as a positive impact on survival, whereas FLT3-ITD mutation has a negative impact on survival. And if you have patients with NPM1 positive, FLT3-ITD negative, typically they do well, and we traditionally don't offer transplant for those patients. If you have a patient with FLT3-ITD without NPM1, typically they do worse, and we offer transplant for those patients. Well, we found there are other mutations. So on average, if you do genomic panel on patients with normal karyotype AML, you find about 3 mutations per sample. So there are some competing interests between those mutations to impact the prognosis of the patient. So for example, another mutations that is commonly seen in normal karyotype is DNMT3A. And also, several studies have shown that it has adverse event. So in this study, we tried to take a look at can we simplify the algorithm, but also provide more data to kind of how do we dissect this group of patients. So we started with the 3 most common mutations, NPM1, DNMT3A, and FLT3-ITD. And then we called those patients cohort the triple positive. And then the other patient cohort will be triple negative. And there are some patients who will have NPM1, DNMT3A with FLT3-ITD positive, negative, or NPM1 positive, FLT3-ITD positive, DNMT3A negative. And what we found, actually, the outcome of all those patients is completely different. So, for example, the triple negative patients, they actually perform better compared to the triple positive patients. So if you have a patient with NPM1 positive, FLT3-ITD positive, and DNMT3A positive, their median survival was 14 months compared to patients, for example, with NPM1 positive, FLT3-ITD negative, and DNMT3A negative, where their median survival was 99 months. And if you have FLT3-ITD positive with DNMT3A, the survival kind of in between. So that's what we try to do here, is try to simplify a little bit still complex problem, but provide wider genomic applications in patients with normal karyotype AML.